Are you going to give a countdown?
Yeah, they will give a count.
Yeah.
So, sir, you start and then I will take over and then
Yeah, sure.
Abraham also.
Good evening, colleagues. A very warm welcome to this fifth session of Heart Failure Physicians course. This is the last but one session. I hope you have enjoyed yourself, and we hope we have been able to update your knowledge in the management of heart failure patients. Next week will be the last session, and that will be followed with an examination. And we wish you the very best in securing your certificate. May I call upon Dr. Hari Krishnan to take this session forward? Hari.
Good evening, everyone. We are into the fifth day of the physician's course. Today we are concentrating on advanced heart failure and end-stage heart failure. First, we'll start with the recap of the previous day by Dr. Amit Malviya, followed by our international faculty support from the Heart Failure Association of the European Society of Cardiology, Dr. Frederick Verbrugge. And then we have sessions on cardiac transplant by Dr. Sundar, then challenging but rewarding case scenarios by Dr. Bhagirath from Bangalore, and case scenarios heavy hearts by Dr. Sandeep Seth from New Delhi AIMS. So before going to Dr. Amit, Abraham, are you around?
Yes, he's here.
Yeah, I'm here.
Abraham, yeah. You have a few words and then we'll go to Dr. Amit.
Yeah, welcome all, and this is the time of DC Universe and Marble Universe. Similarly, this is part of our Heart Failure Association of India Universe of Academics. So there will be lots. This will be the second last of this session, but we'll have a lot of physical meetings, updates about ESC congresses, HFSA congresses. So enjoy the academics, and let's go on with the session. Thank you very much.
Over to Amit for the recap.
My screen is visible, sir?
Yes.
Yeah, please go ahead. Yeah, it is.
So good evening, everyone. Last week, we had a very, very interesting and educative session. There were four lectures given by eminent people in their respective fields. And the first one was by Professor Justin Paul on peripartum cardiomyopathy. He gave a very comprehensive overview of PPCM and touched upon all relevant and contemporary issues with help of case-based illustrations. So I'll just summarize the main things, main summary of his presentation. So basically in PPCM diagnosis, the most important which was conveyed was that it is a diagnosis of exclusion, and all other causes should be exhausted in detail before labeling anyone as a case of peripartum cardiomyopathy. Then he went on to discuss about the management of heart failure in pregnancy. And the main message there was that if the patient is unstable, you treat it as any other acute heart failure. But if the patient is stable, then the management differs, and it basically you have to think about the medical therapy in terms of fetal and maternal toxicity, myocardial damage. What are the drugs which are to be used? What are the drugs which are not to be used? And the drugs which can be used, everybody knows that hydralazine, nitrates, beta blockers, and diuretics. Then it was discussed about the mode of delivery, and the preferred mode of delivery in such cases of PPCM is always vaginal. And there are only certain indications of cesarean section. And it should not be, vaginal delivery should be promoted unless there are very specific indications for a cesarean delivery. Then bromocriptine and prolactin inhibition was discussed in detail. There are a lot of studies were discussed. But the main message was that although it tends to improve LV function, and a little bit improvement is seen in the mortality, but it is not statistically significant. And as of now, bromocriptine should be started only in very severe PPCM, and only if you can catch them early, and in a dose of 2.5 milligram twice daily for 2 weeks, followed by increase in dosing. And anticoagulation should always be started while using bromocriptine, and bromocriptine should never be used in antenatal period. It is only for the postnatal period usage. But as of now, the role of bromocriptine is not crystal clear. It's still a bit doubtful. Then, as I said, GDMT in PPCM was discussed. It was discussed what medicines in what doses should be started. And last but not the least, there were two important things: recovery of LV function, which we know all we know is very, very important. And there are certain recovery scores are there. Recovery varies from 6% to 95%, depending on various factors like LV dilatation, QRS duration, symptoms onset, and what was the duration of symptoms, etc., etc. And subsequent pregnancy in PPCM patients should be avoided because the maternal mortality increases a lot. And that is how he ended his presentation. The second presentation was about tachycardiomyopathy, and it was basically a lot of cases, practical cases were presented, and by Dr. Narasimhan, and he enumerated how the treatment of arrhythmias can lead to improved outcomes in heart failure patient. So tachycardiomyopathy, basically it's either arrhythmia-induced reversible fully or partially left ventricular dysfunction, or sometimes it is arrhythmia mediated, means those who already have a pre-existing structural heart disease and arrhythmia worsens it. So in both of these, the treatment of arrhythmia is important to have a better prognosis. The mechanisms of tachycardiomyopathy are various, molecular and macroscopic, but basically it's ATP depletion, oxidative stress, and ischemia leading to the macrovascular changes in the myocardium. Then he discussed about catheter ablation of atrial fibrillation in heart failure, and a lot of things were discussed about the Castle AF study. And the main message was that ablation at any given time is better than medical therapy only, and it should always be promoted. One other thing, very important thing, which he discussed in a great detail, was the therapeutic window of antiarrhythmic drugs. It gets very shortened in patients of heart failure, and whatever benefit they get from AADs by correcting the arrhythmias is offset by the side effects on myocardium as well as other systemic side effects. So ultimately, AADs may not be a very great choice for treating arrhythmias in this group of patients, and ablation should always be considered as a first choice. This was his main message from his presentation. The third presentation we had was a very, very exhaustive, very, very lengthy and very, very educative presentation by Dr. Sanjay Mittal on chemotherapy-related cardiomyopathy. And he covered right from the incidence of cardiotoxicity to mechanisms, what are the types, what is the recovery of cardiac function after and before this chemotherapy-induced LV dysfunction, how to risk stratify these patients, and what are the prevention. So basically, chemotherapy can cause various type of cardiotoxicity. It is can cause LV systolic dysfunction, arrhythmias, myocardial ischemia, thrombophlebitis, pericarditis. I mean, there are multiple mechanisms. And this myocardial toxicity basically is two types. One is reversible and the other one is irreversible, depending upon the presence or absence of permanent myocardial necrosis. The recovery of cardiac function also, it depends upon various factors, including the type of chemotherapy, the duration, pre-existing conditions, comorbidities, etc. And it is classified as basically responders, partial responders, and non-responders based on the percentage or point improvements in LV function after the treatment. And this cardiotoxicity definition, they have been defined in two basic groups: asymptomatic and symptomatic, mild, moderate, and severe. Basically, as I said, based on the percentage point improvement in the LV function. The prevention of this chemotherapy-induced cardiomyopathy is primary and secondary prevention. Primary prevention is basically proper screening, baseline CV assessment risk, and avoiding using of these cardiotoxic drugs. And once they have it, the treatment is more or less similar to any other heart failure. But there are certain drugs which are known to have some benefit in this type of cardiomyopathy, that is ACE inhibitors, beta blockers, and statins. But otherwise also they are a part of a standard GDMT for heart failure. So the management part does not differ much. The difference comes from the primary prevention and risk stratification. And last but not the least, the last presentation was by Professor Mullens, and it was really a eye-opening presentation. I mean, he basically dealt with mindset of cardiologists and physicians. Apart from the real theoretical knowledge, he discussed in detail about the indications and benefits of ICD and CRT, and what are the management protocols, how to follow up these patients. But I have listed here some of the important things which he said. The most important, which I found was very interesting, that it must be offered to your patient. The resistance is mainly from the physician or the cardiologist side. And he showed us one slide where he said 1 out of almost 100 patients in countries like India actually get a CRT or ICD out of 100, those who really need it, compared to very high figures in Western countries. The second important thing that he discussed about the CSP, and he said that CSP should only be considered where this coronary sinus placement of lead fails. It should not, because there is no current evidence that CSP is superior. There is no RCT to say that CSP is superior or equal to CRT, conventional CRT. And integrative approach is must. As you can see that the risk of sudden cardiac death is higher in countries where the usage of ICDs is low compared to countries where the usage of ICD is high. So we have to promote the usage of ICD wherever it is indicated. The resistance has to go down. And this is a very interesting slide he showed, that you see the number need to treat, the impact of mortality. CRT is just next to MRAs. It is 8. If you see the others, you will see the figures go in double digits. The single digit figures is only beta blockers, MRA, and CRT. So ICD and CRT are something which are to be promoted well over the current this thing. And in furtherance of this point, he showed many studies and slides where it was shown that GDMT devices are superior to GDMT, especially with a wide QRS. And then he dealt about a very important topic, whether all patients should who are undergoing for CRT should be implanted CRT-D or they should get CRT-P. And basically, when the patient, you are putting a CRT for secondary prevention, or their genetic mutation related cardiomyopathy, or their myocardial scars demonstrated by imaging, then CRT-D is preferred. Otherwise, generally, CRT-P is a better choice. And I have already discussed about CSP and versus CRT. This was he discussed this in at length. And last, the most important aspect of management is CRT optimization. Putting only implanting is not enough, and multidisciplinary care with proper this thing improves the outcomes a lot. So this summarizes all the 4 lectures from the last week's session. Thank you very much.
Thank you, Amit, for that nice overview of the last session. Now we will move on to the presentation by Dr. Frederick on acute heart failure. Over to Dr. Frederick. I think it's already recorded. He will join for
Privilege to be invited at this exciting course by the Heart Failure Association of India, talking about advanced heart failure. What is the current strategy of management? These are my disclosures. You can see that I've been working together with many of the medical companies for both devices and pharmacological treatment for heart failure. When we look at the trajectory of a heart failure patients, then we can kind of deline 4 phases in this. And with these 4 phases come different therapeutic goals. Of course, first, heart failure needs to develop, and one goal can be to try and prevent this, or at least, if this is non-preventable, have an early diagnosis. This is a little bit outside the scope of the current talk. And then, of course, once you have that heart failure diagnosed, we as heart failure specialists should try to come as close as possible with, I would call, heart failure remission. And when you think of heart failure remission, this is complete restoration of the systolic function without any scar zones in the heart, the absence of congestion, without the need of maintenance diuretics. And this is the scenario where we have like perfect heart failure remission. I think, for instance, of myocarditis associated with heart failure, no residual scarring, complete restoration of the function and no residual congestion. Of course, with many causes, many underlying diseases for heart failure, a complete remission is not always possible. If we have a scar zone because of a myocardial infarction, then this will remain scar zone. That meat will never beat. So many cases, most cases with heart failure, we cannot go to complete remission, and there remains an elevated residual risk. And at a certain moment in time, this risk starts to decompensate, and we get decompensations and we get gradual worsening of heart failure. This is the time where, after an initial gain in risk, we get a deterioration again. And we can try and prevent those decompensations to improve the heart failure and slow down the disease progression. But eventually we might ending up in a situation where the risk is very high, and we should consider advanced options such as transplant, mechanical support, or if the patient is no candidate for that, palliative care. So what I'm really going to focus on in this talk is this trajectory from residual risk to decompensation prevention. So the middle part, like there will be other talks later on transplant and LVAD. So we know, of course, that heart failure pharmacological therapy is a big success story. And this is kind of an overarching nice paper in Lancet, using basically the data from the big pharmacological studies, and it compares the treatment of heart failure with reduced ejection fraction from the time that I was in med school. That is not so long ago. I'm around 40 years old now, versus the current 4-pillar therapy. So this is basically ACE inhibitor and beta blocker versus ARNI, SGLT2, MRA, and beta blocker. And what you can see is that those old therapies already had a substantial gain in the disease-free survival. But with the new therapies, we can gain an additional 7 years of life. When we diagnose the heart failure early, around 55, then the difference is 7 life years that we can gain. So early diagnosis is important because the impact of the drugs is the largest there. And getting those drugs as soon as possible and as complete as possible aboard will help us to come as close as possible with heart failure remission. Now, of course, there are many patients, the easy heart failure patient, where we can just up-titrate all the drugs easily and they do well. But many patients with more advanced, more severe heart failure, this is more difficult. And it can be interesting to think a little bit about hemodynamics in advanced heart failure to see how we can strive to really optimize patients on good heart failure drugs. And when we take it to two scenarios, heart failure with reduced ejection fraction and poor pump function on the left and preserved on the right, the problem with heart failure with reduced ejection fraction, it is contractility. It is a low end-systolic elastance. So you know this is the Frank-Starling curve. When this curve drops, you have a poor contractility. Of course, there's also a passive compliance. This is the left ventricular compliance. And then basically there's also an arterial elastance. So this is a kind of the determinant of afterload. This is determined by the heart rate and the systemic vascular resistance. So higher heart rate, higher systemic vascular resistance means a higher arterial elastance. And those determine basically the pressure volume loop and the stroke volume. And we can see that in a patient with heart failure with reduced ejection fraction, because this end-systolic elastance is low, the heart starts to dilate and the stroke volume and the curve is shifted towards the right. When we look, for instance, in comparison to HFpEF, there we have quite a normal contractility, so a better end-systolic elastance. But here the problem is much more the compliance. So with the same afterload determined, the same heart rate, the same systemic vascular resistance, the same stroke volume, and also the same blood pressure, actually you can see that this is a curve that is much more to the left. So this is smaller left ventricular volumes. The reaction towards, for instance, a vasodilator will be totally different. So if we, in the first example, use a vasodilator to reduce the afterload, what you can see is that we win a lot in stroke volume, and we have just a tiny drop in systolic blood pressure. This is because the curve is shifted towards the right. So towards the left, we have an improvement in stroke volume possible with afterload reduction. If we have heart failure with preserved ejection fraction, actually there is not so much space towards the left, and we are going to see a much larger drop in blood pressure for a much more limited gain in stroke volume. So basically, heart failure with reduced ejection fraction and small stroke volume, small cardiac output is afterload dependent, while HFpEF patients are much more preload dependent for their stroke volume. So this means it is important to think of stroke volume, and I would urge you to test the stroke volume. It's important to look at pulse pressure. I often say this is the cheap man's Swan-Ganz catheter, because we know that the stroke volume, it corresponds really good to pulse pressure. And realize that if you have a patient with low blood pressure, 90/70, so a relatively low systolic blood pressure, but a relatively high diastolic blood pressure and a small pulse pressure, actually this is a patient with a mean arterial pressure of 77, so really preserved, but a tiny pulse pressure, and so nearly an impaired stroke volume. And these patients, those patients with preserved mean arterial pressure, with preserved diastolic pressure, but a low pulse pressure, you already know that this patient is going to have exaggerated vasoconstriction. And these are patients with very often advanced low output heart failure, small stroke volume, elevated filling pressures, where if you give them some vasodilators, you will decrease the afterload, and you will, for the same blood pressure, you will get much more forward flow. You will get a higher cardiac output. Wilfried Mills nicely showed that if you use this strategy with nitroprusside, which is a potent vasodilator in advanced low output heart failure, you can actually improve the prognosis. This is observational data, but from the similar group in the Cleveland Clinic, you can see that actually what happens is that when you give nitroprusside, you increase the cardiac output, you lower the filling pressure, the pulmonary pressure, and you normalize the systemic vascular resistance. And when you have optimized those hemodynamics with an IV therapy, it is also easier to subsequently switch towards Entresto, an ARNI. So you can use this hemodynamic guided therapy to kind of enable your disease-modifying guideline-directed medical therapy. And you can take this to the extreme. Of course, vasodilators can be a bridge towards GDMT. But this is a study that we did at our center, where we used patients in cardiogenic shock under Impella support. And what we basically did was aggressively uptitrate the heart failure drugs in this population. You can see that these are patients under a pump support, where we got 94% on an SGLT2 inhibitor and MRA, and 83% on sacubitril valsartan. Using the pump support to uptitrate the heart failure drugs. And what we saw was that actually we had a good amount of recovery, and basically 75% of those patients recovered. We had a mortality of 25%, which was significantly better than when we looked at our historical cohort with ECMO and balloon pumping. This kind of shows the idea. So classically, we want to optimize drug therapies first, and then consider device therapies. So this is the established form that is in the guidelines. But one possibility that we are more and more interested in is also to use device therapy, such as maybe an Impella pump, but it could be also a TEER or cardiac resynchronization therapy, to create a hemodynamic situation that allows us to enable or uptitrate the GDMT. And this GDMT will then improve the cardiac function, help the recovery to have a better function of that device therapy. So this is really something that we should look into the future much more. Cardiac resynchronization therapy, it's probably the device therapy that is the most well established in the guidelines. We should always consider it in those patients like here with a broad left bundle branch block and clear desynchrony. Here you can see apical wrapping, septal flash. So this is the ideal CRT candidate. You should never miss this patient, because we know that if you have mechanical desynchrony, then this is not going to improve by drugs. So if you have LBB, if you have a widened QRS complex, you can see that actually the remodeling with your guideline-directed medical therapy, it's actually much worse. So this is why you should not miss out on opportunities of patients to resynchronize. This is a study we did together with Wilfried Mullens when I was at Genk. So we looked at basically the moment that patient got a CRT indication, and then the time we waited to implant the CRT. And the longer you wait for an appropriate CRT indication, actually the worse that your patient is going to do. So implanting early enough before you get organ damage, it's also important. Of course, there's a big thing about non-responders of CRT. We should kind of change this terminology, because non-responders should only be a patient that worsens after the CRT. If you have a patient who has, for instance, a genetic cardiomyopathy, this disease is going to progress over time. So if you can delay this progress, this is actually also a gain that you have. So this you can consider as a partial remission. And so I would argue that if you have good criteria and you have the synchrony present, you will never worsen the patient with a CRT. And actually, the most important reason for non-response, we know that per million inhabitants, probably you should be around 400 CMT implants, and we are only halfway that number. These are data from 2019. So 50% of CRT patients or CRT candidates are not implanted, and these are the real non-responders. So there is still massive underuse of CRT. Next thing we should then consider after we have optimized the therapy done maximally to enable the guideline drugs and consider the need for a CRT is whether we should add a defibrillator, yes or no. What we should realize, therefore, is first of all the sudden death risk, of course. We still use ejection fraction mostly. If it's persistently below 35, we should consider the ICD. But always, it is also important to consider the competitive risk. If it's a patient with a lot of comorbidities, then maybe the sudden death risk might be high, but the competitive risk might be even higher. So it's always a trade-off between sudden death risk and competitive risk. To the contrary, a very young patient with a genetic cardiomyopathy that has maybe an ejection fraction of 40%, but has a very long time of exposure and probably chance to worsening, we might consider the ICD as well, especially when it's a negative or pathogenic mutation. But even when we implement all those therapies in the most optimal way, and I have now taken, for example, the last SGLT2 inhibitor study where the background therapy was really optimal, you can see that there is actually still a large residual risk for decompensation. And we know that if we have decompensation, the patient never recovers to the level that he was before and will start to gradually decline over time. So if we can have a strategy where we can prevent those decompensation, we might be able to slow down the disease. And this is the idea behind pulmonary pressure monitoring. So instead of waiting till hospitalization happens and then being reactive, we know that the filling pressures start to rise from 21, for HFpEF it's a little bit shorter, it's up to 10 days before the event. And so when we recognize this increase in filling pressures and we do a preemptive treatment, for instance, increasing dose of diuretics, we might prevent the decompensation. And if we prevent the decompensation or make the decompensations much less worse, we might slow down the disease trajectory. There are now at least 3 devices that are commercially available in the world. So CardioMEMS is the most well known, but there's also the Cordella system, now acquired by Edwards, and the VLAP. So this is an example of a patient at our place. You can see that pressures start off quite high with a lot of therapy changes in the beginning, and we managed to get this patient to really stable and low pressures. And this patient was not a single time readmitted, although he had a ventricle of 9 centimeters. And actually right now, last week I saw him, and after 3 years, we are now considering LVAD. So we want 3 years for LVAD. So basically what is offered to you by the pulmonary pressure monitoring, it is a more dynamic change in diuretics. Not only up titration, but also down titration. A common scenario is that a patient comes into your outpatient clinic with congestion, you increase the dose of diuretics, and then 2 weeks later he come in with acute kidney injury. And you wonder, was this a wrong decision? No, it was probably not a wrong decision if the patient had true congestion, but at a certain moment in time, you have missed the point that he or she became euvolemic and you should down titrate again. And with dynamic pressure monitoring, you should have a better individually titrated diuretic therapy, which is really useful for patients with really difficult to treat advanced heart failure. Tips and tricks for using your oral diuretics is that you should know that if the GFR becomes lower, then you should increase your dose of diuretics. So these are the doses that I currently consider. So I use mostly bumetanide or torsemide in patients who are treating orally because they have a better bioavailability. And so I use doses of half to 1 milligram or 5 to 10 milligram torsemide for eGFRs that are quite normal, above 40. But once you drop below 40, you should increase the dose of loop diuretics. So the first thing I always look, the patient has congestion or elevated filling pressure. Is my dose still adequate for the kidney function? So if the dose is adequate, then probably this patient is eating a lot of salt, has dietary errors. So we try to focus on there, and we will increase the frequency. So know that 2 times 1 milligram of bumetanide is not the same as 1 times 2. So the dose is more dependent on the kidney function. The frequency, it is dependent on the amount of congestion, the amount of edema that is present, and the adherence to low sodium diets. If you have patients who, despite adequately dosed diuretic, are not responding well, then you could add a thiazide. So we add always chlorpeladone in Belgium, but if you like metolazone or another chlorothiazide, then I think that is equally well. But again, also dose appropriately. If you use hydrochlorothiazide, don't use 12.5 or 25, use 50 to 100 milligrams. So dose adequately. In those patients who tend to have hyponatremia, you might consider acetazolamide as an alternative. What we then often do in those patients where we have optimized the treatment, optimized the hemodynamics, put in a cardiomams to be really sure that we have a good hemodynamic balance and we got rid of the congestion. In those patients who then develop worsening MR, we try to really select those patients. In our opinion, these are the best candidates for MitraClip. So this comes after the hemodynamic optimization, not before, because sometimes also with getting rid of congestion, you will improve the mitral regurgitation. But again, if you then come in that situation where you have progressing mitral valve regurgitation, then TEER is again something you could consider to eventually gain some time and delay the time that you need to go to LVAD or transplant. So to conclude, in advanced heart failure, the ultimate goal always remains complete heart failure remission. We use the 4-pillar therapy for it. This is complete restoration of systolic function and getting rid of congestion, but often this is not entirely achievable and we have a partial remission. To enable those disease-modifying guideline-directed medical therapies, we can use vasodilators in low-output heart failure. We might consider also devices, certainly resynchronization therapy. We have a lot of evidence for that. Maybe also in cardiogenic shock in the future, microaxial flow pumps. We have small pivotal studies showing that there is something in that direction too. Cardiac resynchronization therapy remains vastly underused, so consider it in all of your patients. Consider also the need for an ICD, sudden death risk versus competitive risk. In most patients, a full remission is not possible, and there remains a residual risk, and then we should focus on prevention of decompensation. We have a proven strategy for that in pulmonary pressure monitoring. This will help you to individually tailor the diuretic therapy. And in those patients who then, with optimized hemodynamics, have progressive MR, I think transcatheter edge-to-edge may be a good option to delay the need for LVAD transplant. Thank you very much for your attention, and happy to take questions.
Thank you, Dr. Frederick, for that very wonderful presentation. So open to questions. So what about use of ionotropes? Any thoughts on that?
So I think that we have no evidence or studies that show that inotropes, they improve prognosis. And of course, they increase myocardial oxygen consumption. So we have been shifting towards less and less use of inotropes. Of course, maybe in India, the mechanical circulatory support depends a little bit on where you are. I think when we anticipate a prolonged need for support, we are going more and more to Impella for supporting the right heart, and a Protec Dua cannula, so a venopulmonary artery ECMO for right ventricular support. I think the best use in advanced heart failure for inotropes is with when you are in a situation where the patient is no longer a candidate for LVAD or transplant, but is in persistent low output heart failure, there I think that levosimendan is a good palliative care option. So we do that these are patients that come into the clinic every 2 weeks for a levosimendan infusion. And with the levosimendan, we are able to keep them out of low output. But this is, and they have actually a much better quality of life. Very often we also stop the ARNI and the drugs that lower the blood pressure, because it also gives a little bit of vasodilation. But their life quality is sometimes pretty good for a few years. So this is really as a palliative care strategy.
You said about vasodilators, and you said the difference between heart failure with preserved and reduced ejection fraction. Thanks for clarifying that point. So nitroprusside versus nitroglycerin, any difference, or you prefer nitroprusside to be used, or what?
So the difference is nitroprusside is a direct NO donor, while the classic nitrates, such as nitroglycerin, have an additional reduction steps. And for this reason, the profile of vasodilation with nitroprusside is very much balanced between the venular side and the arterial side. With nitrates, it is much more venous dilation. So when your goal is afterload reduction, such as this in low output advanced HFrEF, then I think nitroprusside, it is the better option if you have it. It's also a little bit more expensive. So we started based on blood pressure measurement. You don't need a Swan-Ganz catheter. So we started at 10 micrograms per minute, and we increased just with 10 up till 250 max, but most patients will end in between 70 and 100 micrograms per minute. And we rapidly increase like every 10 minutes based on the highest dose we can achieve with a map around 65. And what you will see is that because you open up the vessels, this reduces the blood pressure, but you also reduce afterload, which increases the cardiac output, which increases the blood pressure. So your mean arterial pressure remains at 65, but you will get a lot more cardiac output, a lot more forward flow, and a lot less organ shortage, a lot less hypoxia.
Abraham, any comments?
Yeah, Friedrich, one wonderful talk. What about milrinone? You talked about intermittent levosimendan. So what about milrinone? And what is the connection between beta blockers and levosimendan? Do you stop beta blockers if the blood pressure is low and then give levosimendan? And
Yeah,
finally, when do you call ARNI is futile in stage D? Life study showed no benefit. But when you, what is the cutoff for futility of GDMT in advanced heart failure?
Yeah, so excellent questions. So first, for the first question about milrinone, I think that actually we don't have much evidence that milrinone is better or worse than dobutamine. It is a little bit more pulmonary vasodilation. So when it is a more primary RV problem, I tend to go a little bit more easy towards milrinone than dobutamine. On the other hand, you can also add inhaled NO, and then probably it is quite the same. So I don't think that one inotrope is necessarily better than another. I think the key thing is to realize that people with a preserved mean arterial pressure and low systolic blood pressure, in spite of what the guidelines say, they are the ideal candidates for vasodilators. And when you have to choose between a vasodilator and an inotrope, with one scenario, the vasodilators, you unload the heart, and this is clearly better than getting the whip with the inotropes. So what I do think is important in heart failure is you don't allow your patient to walk around wounded. So they shouldn't be in low output. They shouldn't be congested. If congested is the problem, then you go to the CardioMEMS device if you cannot do it with a diuretic schedule. If the problem is low output, then I think usually this is the time where the patient should be considered for an LVAD or a transplant. And if the patient is no longer a candidate for an LVAD or a transplant, then I think this is the place where palliative inotropy comes into place. And there, the only reason we prefer the levosimendan, we used to do it with a subcutaneous pump of dobutamine, but it's much easier with 2 weekly infusions of levosimendan because it's so long working. And basically, from the moment I start a palliative inotrope, this is the moment where I consider the neurohumoral modulation not longer essential because I will be focusing on life quality there and on hemodynamics and lesser towards ventricular remodeling. You probably have already missed the opportunity for remodeling, and the patient is really end stage.
Okay, Bhagirath.
Yeah. My question to Dr. Frederick. First of all, congratulations on a fantastic talk. I want to know from you when you said regarding palliation using inotropic support, oftentimes we send the patient on milrinone infusion and then observe them and ask them to come back periodically for refills. I also understand you can use dobutamine, you can use levosimendan. So my question to you is, how do you overcome the phenomenon of tachyphylaxis, and do you use these in rotation, especially because levosimendan is licensed for use for 24 hours, after which you have to make the change. So how in your center do you deal with this particular problem?
So usually what happens if we see a patient in the outpatient clinic who we think is low output or persistently congested, is we have a special right heart cath program where the patient is admitted, and then we do hemodynamic guided therapy. So if we determine that in this hemodynamic guided therapy, the patient is in persistently low output, we cannot get them out of it with inotrope, this is the moment that we decide we're going to start the palliative care program. I think you can perfectly go for a dobutamine pump, or you can go for intermittent milrinone or levosimendan. From all those products, levosimendan has the longest half-life. So I think that it is the best suited. So what we basically do is the first administration we give over 24 hours at the CCU. And if the patient tolerates this well, then we will give the next administration after 2 weeks in which is our daycare unit. Patient comes in the morning and goes home in the evening. And the second administration we will do over 12 hours, and we will give the same levosimendan dose first 12 hours, 8 hours, 6 hours, and eventually even 4 hours. And so most of our patients with palliative inotropes, they just get a complete ampoule of levosimendan in 4 hours after a couple of weeks, and they tolerate that really well. Sometimes they are a little bit hypotensive, and this is when we come down with the heart failure drugs. I realize now that I also didn't answer the question on the beta blockers. I think a misconception on the beta blockers is that we should always try to keep them. I always like to keep the beta blocker if that's possible, but I never keep the beta blocker if the patient is in low output. That it means the patient is actually in cardiogenic shock. And so what sometimes can be helpful is in a patient that is cold and wet is take away the beta blocker, decongest the patient well, up-titrate all the other treatments and optimize, and then slowly reintroduce. And sometimes I also temporarily take away the beta blocker. If they are tachycardic, I give them Procorlan, ivabradine, and then once we have up-titrated the ARNI, the patient gets a little bit of remodeling, then they will tolerate the beta blocker better, and I reintroduce a tiny dose before discharge, and then go very slow in up-titration. If I have patients in the unit, I can be quite quick with up-titrating the ARNI, especially when they are vasoconstricted. They tolerate very well rapid up-titration, but you should keep away the beta blocker and keep it to the last. So that can sometimes really help. And in those with palliative inotropes, usually they are not on beta blockers anymore.
Thank you, Dr. Frederick. I think because of the very good discussion, very good talk. Thank you so much. So one question from contribution by digoxin to morbidity in advanced heart failure. digoxin, do you use it still, or that must be the last question.
So I think that my role for digoxin is more in right heart failure. So I tend when I have biventricular and right heart failure, I tend to add it, and my impression is that it there helps a little bit the right ventricle as well. So especially those with AFib and right ventricular failure, I add it.
Okay, thank you, Dr. Frederick. Thank you for the nice talk, and we'll move to the next presenter, Dr. Sundar.
Bye-bye. Thank you for the invitation.
Thank you very much.
Good day to you all. I would like to thank the organizers for inviting me to give this talk on heart transplantation, when to refer, outcomes, and long-term care. My name is Dr. Sundar. I'm a cardiothoracic and transplant surgeon from Kaveri Hospitals, Chennai. I have no disclosures to make, and I acknowledge the use of guidelines from the International Society for Heart and Lung Transplant and the Heart Failure Association of India. To give an overview of my talk, I would stress that this is an audience-specific talk directed primarily at physicians and cardiologists looking after heart failure patients, stressing upon the need and when to refer for heart transplantation. I would begin by talking about the changing landscape of heart failure medical therapy, and so much has been done in the last few years. There has been need for revisions and updates of guidelines. What are the current indications for transplant, and when do we refer the patients for transplantation, followed by the evaluation of patients for heart transplant candidate, talk about postoperative care and outcomes. Most of this has been taken from the guidelines most recently published in 2024, Care of Cardiac Transplant Candidates by the International Society for Heart and Lung Transplant, and also our own Heart Failure Association of India 2025 Guidelines for the Diagnosis and Management of Heart Failure. So transplantation, I must stress, is a salvage procedure in a desperate situation. We all need to agree and we all need to understand that it is a trade-off. In return for relief of symptoms and breathlessness and survival benefit, we agree and accept the complications and problems of mandatory immunosuppression. Central to heart transplantation is a heart failure team. It comprises of heart failure and interventional cardiologists, the cardiothoracic transplant surgeons, cardiothoracic anesthetists, intensivists, and multidisciplinary team. The much talked about early referral does not necessarily mean immediate transplantation, but periodic assessment and evaluation of the patient. We do have objective scoring systems such as the Columbia Heart Failure Score and Seattle Heart Failure Score. And with this, we are able to identify optimal time to transplant when the outcomes are the best, which is referred to as a transplant window. An often quoted mnemonic for timely referral for advanced heart failure therapy is I need help, I standing for inotropes, N NYHA class or even NT-proBNP, E is an end organ dysfunction, the second E refers to a low ejection fraction, and D is frequent requirement for defibrillatory shocks. The HELP H stands for hospitalization. E again is edema or the need for escalating diuretics, low blood pressure, and prognostic medications. So heart failure patients, as you all know, need optimal medical therapy. We need to ensure that they have maximum dose of standard medical therapy, which we call goal-directed medical therapy. That is the maximal tolerable doses. There are some patients whom you can't use all these medications due to side effects. The last few years have changed the outlook for heart transplant with discovery of new molecules from the traditional diuretics, beta blockers, ACE inhibitors, ARBs to ARNIs, SGLT2 inhibitors, and GLP agonists. Devices such as transcatheter MitraClip have also improved the outcome of these patients. So one needs to assess the severity of heart failure, and we can do that objectively by a CPET machine, which is a cardiopulmonary exercise testing machine, which allows us to calculate the VO2 max, which is the maximum oxygen consumption in mils per kg per minute. We could do that using either a cycle ergometer or a treadmill. RHT stands for right heart catheterization, to measure the pulmonary vascular resistance and the pulmonary pressure to identify patients in whom transplant can be safely done or who are not candidates for transplantation, and 2 prognostic scores that we discussed about to help decide. The scoring systems are the Columbia Heart Failure Scoring System and the Seattle Heart Failure Model. The Columbia Heart Failure Scoring System uses various parameters, but for this, a CPET machine is mandatory for scoring it, whereas the Seattle Heart Failure Model can be done on an app in our outpatients, just putting in the clinical details. So the Seattle Heart Failure Model can predict the 1, 2, 3 survival. It does not use VO2 max. And if the 1-year survival is less than 80%, we consider referral for transplantation. And an ambulatory patient, this is the algorithm. On the left side, if they find the VO2 max by CPET is less than 10, or the predicted 1-year survival is less than 80%, and the heart failure survival score is high risk, you list. On the other end of the spectrum, when the VO2 max is more than 14 or the 1-year survival is greater than 90%, you do not list. Between these two is a gray area where you have to make individual decision. Now that's what the transplant window that we spoke about. If the patients are too well, you don't refer for transplant. If they are too sick, you can't do a transplant. Between the two, you find the optimal time, which is shown graphically here. On the left side, patients are too well. On the right side, they are too sick. So you need to find the space, the absolute timing, what we call the transplant window, where the results are the best. So what are the indications and who needs a transplant? End-stage heart failure, despite medical therapy, they remain symptomatic. All options have been tried and nothing seems to work. They could be disease of coronary arteries, ischemic cardiomyopathy, or hypertrophic restrictive and dilated cardiomyopathy, or heart failure due to valve disease. The slide lists the absolute contraindication. The one is when the life expectancy is less than 2, or there is an active current malignancy or life-threatening sepsis. This slide relates the relative contraindications, which can be worked about, and once those conditions are handled, we can think about transplantation. Of note is, the point I would like to make is the most recent guidelines have shown that the indications have expanded. What was once considered not an indication, now with improved therapy and results are being included in the indication. Age for one. 10 years ago, 60 was perhaps the cutoff. 10 to 15 years ago, now we accept up to 70. Again, the BMI up to 35. Cancers are individualized, while acute and active current malignancy is a contraindication. Soon after, after varying periods of time, we can consider heart transplantation. Similarly, indications have been extended in various conditions listed here. So when you look at the recipient for a heart transplant, you look at the indications and contraindications we spoke about, and how do we work up patients. The patient factors are, when there is a current active malignancy, you don't do the operation, and they initially wanted a 5-year cancer-free interval in solid organs, although those intervals are reducing now with extended indication. Skin cancer after curative operation within 1 or 2 years based on the stage and the grade of the skin cancers. So these are individually decided based on the organ in which the cancer has happened. So evaluation of organ functions and comorbidities. This lists the various organ systems which need to be evaluated from the head down to the foot. Cardiac investigation, we need to make sure the patient has got end-stage heart failure and we have exhausted all transplant options before we consider, starting from ECG, echo, whether you can have a revascularization, you need to confirm it with perfusion studies, nuclear medicine, or a cardiac MR to assess for viability. If there is a viable myocardium which can be revascularized, that is what we need to do rather than do a transplant because of the inherent risks of transplant. And CPET machine helps in deciding. when you can list for transplant. If you look at organ systems, end organ damage is quite important. It needs to be looked for, and the end organ damage in heart failure is more due to back pressure and congestion than due to forward flow deficiencies due to low cardiac output. And the organs commonly affected by vascular congestion are the lung cardiopulmonary syndromes, cardiorenal syndromes, and the liver, which is cardiohepatic syndromes. So the single most important assessment for heart transplantation is the assessment of the pulmonary artery pressures. You look at the right heart pressures, do a right heart catheter, measure the transpulmonary gradient, which is a numerical value which is obtained by calculating the mean pulmonary artery pressure and subtracting the wedge pressure. So that is the pressure across the pulmonary vascular tree, and when the DPG is less than 10, you list for transplant. Above 14, it's a contraindicator. Talking in terms of pulmonary vascular resistance and Wood units, 2 to 3 is acceptable, 4 and above is irreversible. So if you have a high PA pressure or a PVR, you want to make sure it's irreversible. You do reversibility study. You give patients oxygen, NTG, dobutamine or milrinone, or even nitric oxide, and see if the pulmonary vascular resistance can come down, in which case you can still do a heart transplant. If despite all this, if the pulmonary vascular resistance remains high, then an isolated heart transplant cannot be done, and we need to think about combined heart and lung transplant. Similarly, renal factors, you need to assess the renal biomedical parameters, biochemical. Look at serum creatinine, eGFR, creatinine clearance in patients. Sometimes you need a renal biopsy. Talking about cardiohepatic syndromes, cardiogenic liver injury, you look at the synthetic function of liver, looking at the albumin level and the INR, enzymes, SCA-OT and SGPT, bilirubin. Portal pressures, you can measure the hepatic wedge pressure, venous wedge pressure. Look at the gradient between the hepatic wedge and the hepatic vein pressure, free pressure. And if the gradient is less than 5, you go ahead. If the gradient is greater than 5, then perhaps he's got severe cirrhosis, which can be shown by fibroscan or liver biopsy, in which case, after heart transplant, you might have severe problems with liver, and you might have to consider a combined heart-liver transplant. Immune screening, you do a tissue typing, and then you also look for presence of antibodies. Allosensitization in the presence of high antibodies can have a higher risk of rejection, and such patients need to be desensitized, treated before you can do a transplant. And such patients will often need a prospective direct cross match. Unlike in kidney transplant, in heart transplant we don't have the luxury of time, so we can't have a cross match for each patient. It's only such patients who have a high antibody levels, who are allosensitized. We have got to use desensitization protocol and see if we can do a cross match before transplant. Situation specific to India is the late presentation with heart failure. Of course, with increasing awareness, we are seeing a change in the referral patterns, and the physicians are referring the patients much earlier on. When patients are referred late, irreversible pulmonary hypertension refers it's too late to do an isolated heart transplant. Complications of heart transplant would be infection because of immunosuppression, rejection, which requires the performance of surveillance endomyocardial biopsy through the internal jugular vein. You pass a bioptome and take biopsies from the interventricular septum on the right side, and then we grade the biopsy and appropriately adjust the immunosuppressive medications. Chronic allograft vasculopathy is a chronic rejection. PTLD is post-traumatic lymphoproliferative disorder, which is malignancy, which occurs after transplants. In addition to these, we have the side effect of mandatory anti-rejection pills. We give triple immunosuppressive therapy, which is steroids, mycophenolate, and tacrolimus, which is a CNI, calcineurin inhibitor. Calcineurin inhibitor is known to affect the kidneys, renal problems, neuro problems, and can also cause hypertension, diabetes. Mycophenolate can cause cytopenias and bone marrow suppression, and steroids has widespread effects, increasing water retention, ulcers, and again, propensity for infections. So post-op surveillance, we need to impress upon patients they need lifestyle modifications. We need to have surveillance tech. We do an endomyocardial biopsy pre-discharge, and then based on that report, subsequent biopsies are done, probably the first 3 months, and then after 6 months and following 1 or 2 years, biopsies are no longer required. Of course, if there are clinical features of rejection with echocardiographic evidence of decreased heart function or development of arrhythmias, which might suggest rejection, we would do biopsies as and when required. Of course, we do have liquid biopsies, the presence of donor-derived DNA, cell-free DNAs, which can differentiate between infection and rejection. And one needs to monitor the progress. We need to have heart failure nurses, heart failure clinics, where they can be seen regularly to make sure they are compliant with medications, do routine investigations to look for any abnormalities in liver and renal function. The outcomes. As regards therapy for outcome, heart transplant enjoys the best outcomes. The median survival currently is a staggering 12 years. Think about it. A patient who had less than 80% 1-year survival now can live 12 years. The 1-year survival now, especially in North America, is in excess of 90%. The 5-year survival is 72 to 75%, with an impressive 50% 10-year survival. Of note, we have 20-year survival of 21%. Amongst the therapies for heart failure, no therapy has got a 20-year survival. So to conclude, I would say as of today, cardiac transplantation remains the most successful treatment for patients with advanced heart failure who are refractory to medical therapy. I thank you for your attention. Thanks.
Sundar, can you hear us?
Yes, yes. I first of all apologize. I'm being driven back home, and
No
I
problem.
hope I'm clear.
Yeah, you are clear. One question is, what is the current transplant statistics in India? Number of procedures per
Yes.
day, etc. Per day, per year, how many transplants we do in India currently?
Roughly. See, we can only give an estimate because the current data collection leaves much to be desired. We can't compare our data collection to your collection, Hari. Kerala leads in, data collection. And these data we arrive at is, Dr. Sandeep Seth is there in the panel, Intran, which is an Indian transplant registry, which is done by voluntary contribution by each center. So far, the last 2023, about 1,400 transplants have been done from the inception, roughly around 250 to 300 per year.
So what are the challenges you face? You said late presentation, late referral. So when a patient is referred to you for a transplant, what are the challenges you face?
Yes. Well, I also did say that the referral patterns are changing and people are coming in the more correct time. And the problems are not necessarily physician related. Physicians do refer early, but there is an inherent tendency in India to try and avoid a surgery till the last moment. And the last moment, we have missed the bus. Barring that, TB is another issue that we face. India is a TB endemic city. And so in a recipient, we can assess for the presence or absence of TB. But whereas in a donor, we don't have the luxury of time. We just have 2 hours to decide. And so we go ahead and take the organ. And then, having TB post-transplant, we have seen quite a few. But those can be easily dealt with medical therapy. And India being, largely patients being self-funded, in the great majority, barring a few government hospitals, like the All India Institute of Medical Sciences and, in Tamil Nadu, Omanjurar Hospital, the great majority of transplants are being performed in the private sector. And there is not much of insurance penetration in our Indian population. A fair amount of people are having to self-fund. I must add that the Tamil Nadu government is having a scheme which gives about 15 to 17 lakh for heart transplant. But barring that, since the majority have to self-fund, cost is an issue. And so there are many people who with difficulty can afford a transplant. Subsequently, they can't afford an endomyocardial biopsy, or even if they do that and the patient has a rejection, to handle rejection or infection, it can be bothersome, and in some patients can even cause financial ruin.
And what is how do you do the panel reactive antibody, and how you said that, but can you little more
Yes.
clarify?
Yes, as a part of our induction, to put another thing in perspective, things have become so standardized. If we have, for example, an 18-year-old dilated cardiomyopathy with a normal liver function, and he has got a normal PVR, the only test needed is HLA typing and panel reactive antibody. If the antibody is zero, he doesn't need much more testing. You can go ahead and do the operation, and the chances of rejection are greatly less given the surveillance we do. And how we do that is we take a early morning fasting sample, because if the sample is taken after food, there is a lot of lipemia, there's a lot of fat in that, and that affects our assessment of PRA, because the PRA is done by a technique called SABA, which is a single antigen bead assay, and they look at fluorescence. So when there's a lot of lipids in the serum, you can get false positive. So we insist on a fasting sample, and that measures the presence of preformed ABO, anti-HLA ABO antibodies. Now that is present in patients, more common in women who have had multiple pregnancies, more often multiple abortions if they have an ABO incompatible children. People with LVAD, after LVAD we do transplant, they have a lot of blood transfusion, and blood transfusion can cause antibodies. But sadly, some patients for no reason at all, de novo, have high antibodies. And our cutoff is when the antibodies are, we see whether it is for class 1 or class 2 HLA antibodies. Class 2 is less problem. Class 1 can cause severe rejection. If the antibodies are greater than 10 to 15%, we start taking anti-desensitization protocol. And how do we know they are sensitive? There is a parameter called MFI, which is the mean fluorescence index. And if that number is greater than 1,500, we believe it is a significant value. We have been leaning on the renal people, the nephrologists, to take their opinion on what level is the cutoff. Because in the Western literature, they say any value up to 5,000 can be considered normal. In other words, you can have antibody levels, and as long as the MFI is less than 5,000, it is okay. But in India, our hospital nephrologists believe 1,500 to be the cutoff. Sorry, that was a pretty long answer. Sorry.
Any comments from Sandeep?
I think one of the things which India faces is that we have a lopsided organ donation in the population, because that's why in southern parts of India, so Chennai, Hyderabad are the main centers where heart transplants take place. And North India, even though we have the full setups, full teams, because organ donation somehow for some reason in Northern India, Central India is not so much, we are not able to push up the numbers. Though more and more teams are being authorized, licensed, but the numbers are not going up. What Sundar is also right is that some governments are supporting the program with funds. So for instance, in Delhi, at least through the RAN funds, we also get 15 lakhs. In fact, I think we are probably the ones who did the first calculation and came up with this number of 15 lakhs. It was based on the mathematics which was done by various centers in the southern parts of India, northern parts of India, that within 15 lakhs, you can at least do a transplant and discharge a patient. So that number has also been used by Karnataka, and for Chennai, everyone are able to give up to 15 lakhs. What we have not been able to achieve somehow is that bring in the post-transplant management in Ayushman or other thing, because they're paying up to initially 60,000 a month and later almost 20-30,000 a month becomes a major issue. And then following up like biopsies, The last patient I did a biopsy had had a transplant in Chennai. So he could not afford going back to Chennai, affording the cost of, I think the cost he was given was 1 lakh. And I could do that biopsy for free. So I didn't make the patient pay anything at all. So that discrepancy will remain. That is true.
So since we are running short of time, we'll move to the next session. Bhagirath.
Good evening, everybody.
Yes, sir.
My slides are visible.
Yeah, it's visible. Please go ahead.
So I'm here to discuss challenging but rewarding case scenarios. Two cases in point to illustrate this. I'd like to thank the entire team of HFAI for giving me this opportunity to present these cases. So let's dive in. So the first case is a 54-year-old lady who presented with history of severe breathlessness, exhaustion, and chest pain. She was a known diabetic since 2 years, not a known hypertensive. She was on medications for diabetes only, and she was not on any other medications. We did repeated inquiries regarding thyroid medications and so on, but this was the only form of medicines that she was taking. On evaluation, the ECG was largely unremarkable, but for some changes in the inferior leads, there were Q waves in the inferior leads. And this is the chest X-ray. Though she came in with some breathlessness, there's some prominent pulmonary vasculature. Other than that, largely unremarkable. This is the X-ray. This is the echo findings, and you can see that the overall LV function is fair, and there's a slight hypokinesia, if at all, in the inferior wall. Apart from that, there aren't any specific regional wall abnormalities or thinning of the myocardium. So on a more zoomed in view, the overall EF is about 50%, mild hypokinesis of the infero-posterolateral segments, and there was mild pericardial effusion. We did a strain image analysis, both of the left ventricle as well as the right ventricle, which soon follows. And this showed that, yes, there is evidence of myocardial ischemia, both in the anterolateral territories as well, that is in the LAD territory, as well as the RCA territory, which I'll be showing soon. We had also seen just now the bullseye plot as well as the assessment of the strain imaging. And again, as I mentioned to you, the ischemic territories were largely confined to the left anterdescending artery and the right coronary artery. This is the RV strain imaging, which also showed that there is evidence of ischemia to the right ventricle. So here we have a patient presenting with a history of breathlessness and chest pain. Myocardial strain shows evidence of ischemia in the LAD territory and the RCA territory. There is evidence of pulmonary congestion, and there's also evidence of pericardial effusion. So this is the LA, left atrial assessment, both in terms of the LA volumes as well as to look at the filling pressures. Next up, we went ahead and did a CT coronary angiogram, which you can see on the panel on the top left and right. The overall calcium score was 496. The LAD showed proximal LAD lesion of 70 to 80% calcific lesion. And also the right coronary artery showed mid-right coronary, mid-RCA lesion of about 80%. Since we have the privilege of doing a two-region CT angiogram, we decided that we'll utilize it to analyze the lungs as well. So there is diffuse smooth interlobar septal thickening. Areas of ground glass opacities are seen. There's mild pericardial effusion. So this adds again that not only is there pleural effusion, there's also pericardial effusion. There's enlarged mediastinal lymph nodes. And of course, there's no pericardial thickening or enhancement, indicating that this pericardial effusion is of fairly recent origin. This is again the overall MRI assessment of the wall motion abnormalities, the severe hypokinesia of the basal and basal to apical anterior wall indicating that likely that there is a LAD lesion in this particular patient. The increased indexed LV ESV and the normal indexed LV and diastolic volume, overall the LV EF on MRI was measured to be 49%. This was then followed up with late gadolinium enhancement, and this showed evidence of multifocal areas of mid-myocardial to subepicardial enhancement, which is seen in the base to apex in the anterior wall, again reinforcing our overall assessment that this lady has, apart from other things, an ischemic heart disease component as well. There's a short tau inversion recovery, that is the STIR images indicate evidence of myocardial edema. Now, when you have the evidence of myocardial ischemia due to an LAD territory or an RCA territory lesion, as well as myocardial edema, the two don't go hand in hand, which means that there is an additional pathology in this particular patient. So we followed up with a T1 and T2 mapping, and this showed that apart from LV dysfunction, there's a non-ischemic pattern of LGE, and corresponding to areas of myocardial edema, raised native T1 and T2 values, and evidence of mediastinal lymphadenopathy. So final impression suddenly moves from, apart from ischemia, there's acute myopericarditis, and it could be granulomatous versus eosinophilic myocarditis versus Churg-Strauss syndrome. So this many diagnoses are the possibility or differential diagnosis in this particular patient. So let's go step by step. We followed up with a PET CT scan in this patient, which showed hypermetabolic mediastinal lymph nodes. There were traces of deposits in the myocardium, as you can see in the still image in the middle. And apart from that, there is evidence of mediastinal lymphadenopathy. So angiogram revealed both an LAD lesion as well as an RCA lesion. So for the LAD lesion, it was balloon dilated, and then we used a scoring balloon and an angiosculpt, and after that we stented it, and with 2.75 into 20 stent, and we got a good result in the LAD lesion. And as evidenced by the various investigations, we also did a right coronary artery angiogram, which showed a tight lesion in the mid RCA, and this was again balloon dilated, and it was stented with a 2.5 into 18 stent. So we got a fairly successful result in terms of the angioplasty. Now let's embark into the next one. We thought that since there is evidence of possibility of acute myopericarditis, we went ahead and did endomyocardial biopsy. And this was basically to see what really is the cause of inflammation, what could be the reason for the pleural effusion, the pericardial effusion, as well as the myocardial edema that I had showed you in the MRI. And to our surprise, it turned out to be that this patient has eosinophilic myocarditis. You can see that this is the spectacle nuclei, which is seen there in the panel in the middle, with a large amount of eosinophils that are distributed throughout the myocardium. So the impression of the various of the endomyocardial biopsy was non-necrotizing eosinophilic myocarditis with subendocarditis. So this was the other pathology that this patient had, apart from the ischemic heart disease. And this also required to be treated, because despite doing the angioplasty, the patient was still not completely okay. She was still exhausted. The blood pressures were hovering around 90/70. The pericardial effusion was still persistent, pleural effusion still persistent. So we decided that this also requires treatment. Now, we did a host of other investigations, and important among them was that the differential count showed eosinophilia, that is 43.3%. Absolute eosinophil count was 6,800 cells per cubic millimeters. No evidence of tuberculosis. We did a gene expert study. There was no evidence of tuberculosis. Again, both the acute phase enzymes, that is the NT-proBNP and the troponin I, were elevated. We also went ahead and did a genetic analysis to see if there's any malignancy involvement, because it's a 54-year-old lady, and then that also turned out to be negative, and the quantiferon TB gold also was negative. So this confirmed to us that this is a case of hypereosinophilic syndrome. So the diagnosis was eosinophilic myopericarditis with hypereosinophilic syndrome. The treatment given to this patient was, as I had already showed you, angioplasty with stenting to the LAD and right coronary artery. Of course, as per standard protocol, antiplatelets and high-dose statins were given. Now, on a different take, the management of eosinophilic myopericarditis is the mainstay of treatment is steroids. The moment the patient received intravenous steroids, she had a dramatic improvement in her symptoms. And we went on to continue this treatment for the next 3 to 4 days in hospital and followed up with oral steroids on discharge. When the patient came back for a follow-up, we repeated the basic studies, including the total count, differential count, absolute eosinophil count. All of them had normalized. If it had not normalized, of course, we have to go to the level 2 forms of treatment in like the methotrexate and cyclophosphamide, which fortunately for our patient, this was not required. She had an excellent response. And subsequently, we have tapered down the steroids, and this patient is currently only on antiplatelets and high-dose statins. A repeat echo, the patient had, of course, a normal LV function, and there was no evidence of any pericardial effusion. X-ray also showed no evidence of pleural effusion, and the patient is doing well now. She's in terms of NYHA class 1 status, extremely active without any issues. So quickly, I'll move on to the second case. What I wanted to highlight is whenever you suspect, when you have a case of hypereosinophilic myopericarditis, the common findings are that there is pericardial effusion, there is pleural effusion, there is increased eosinophils in the differential count, absolute eosinophil count is increased, and the acute phase reactants are increased. But my second case is trying to, the purpose of presenting this is to give you a different take on possibly the same problem. So my second patient is a 37-year-old male patient who presented with history of severe breathlessness, exhaustion on exertion. He had no history of any fever or chest pain, not a known diabetic or hypertensive, non-smoker, no alcohol consumption. He presented with a large pericardial effusion in cardiac tamponade. And as we were analyzing him, we rapidly progressed into cardiogenic shock. We drained the pericardial effusion and found that he was hemodynamically unstable. The LVEF was just 25%, and he was immediately put on percutaneous ECMO by just shifting him from the ER to the cath lab. And we did a percutaneous ECMO for this particular patient to save his life. This is the ECG on arrival. You can see there's a low voltage complex, poor progression of R waves in the anterior leads. And this is the chest X-ray. You see the X-ray to your left that we had floated in a catheter to get the pressures as well. And subsequently, this patient, I told you, had a large pericardial effusion which had to be drained. So this is the image on arrival in the ER, and then the pericardial fluid was drained. Now, interestingly, we sent it for analysis and found that there is a huge number of eosinophils in the pericardial fluid. Now, this, since we had dealt with the previous case just a few days back, we immediately thought that could this be another presentation of the same problem. So this was the echo, largely overall normal LV function. This is, of course, after the drainage of the pericardial fluid, 4-chamber view, parasternal long axis view. This is the short axis view. Then you see the aortic valve contraction. And then this is the color imaging, which shows just trace mitral regurgitation. And there is hardly any tricuspid regurgitation. We followed up with doing an MRI for this patient, early dilated LV with an LVEF of 25%. There was also a dilated LA and a mild MR, early dilated RV with RVEF of 31%. So it was essentially a biventricular dysfunction, dilated RA with moderate TR. There's multimorphic myocardial enhancement with raised native T1 values. So again, suggesting that possibly this could be either a chronic inflammatory or granulomatous disease. It's definitely looked to be a non-ischemic origin and suggested for the PET CT or endomyocardial biopsy. Now, since the patient was at that time on ECMO, it was difficult to transport the patient for a PET CT. So we decided to continue and follow up with a endomyocardial biopsy. Now, this is a more in-depth analysis of the MRI. The LGE showed focal areas of transmural enhancement of mid-inferior segments, as you can see in the arrows, and also subtle myocardial edema in the mid-inferior segment. This is corresponding to the enhancement. So here again, as I had showed you in the previous case, there is evidence of myocardial edema, which again brings to the spotlight the possibility that this patient has an inflammatory process that is going on. This is the cine image. Again, it shows that there is small areas of hypokinesia, and also there is evidence of myocardial edema that you can see in this particular patient. The T1 and T2 mapping, both the values were raised. Here again, this brings up the suspicion that this is again a possibility of myopericarditis that is there in this particular patient. Since we wanted to rule out myocardial ischemia, we just did a diagnostic coronary angiogram, and in this case, the angiogram turned out to be totally normal. We followed up with a myocardial biopsy, and lo and behold, once again, the same picture of multiple eosinophils seen, and including the spectacle image that you see on the panel in the lower right. So once again, the same diagnosis. My purpose of presenting, you can see that huge number of eosinophils are seen in the biopsy specimen. So the purpose of me presenting both the cases to be the same is to show how varied the presentation can be, and you need to have a high index of suspicion. The giveaway in this particular case was the presence of eosinophils in the pericardial fluid. So that triggered us to investigate further and find out what exactly was the possibility in this particular patient. So final diagnosis, again, severe eosinophilic myocarditis with subendocarditis. The ECMO was then weaned off and supportive treatment given. The patient stabilized. Again, improved dramatically with giving intravenous steroids followed by oral steroids, and a repeat echo at 6 weeks, totally normal LV function, no evidence of any pericardial or pleural fluid collection. So to summarize, the definition of eosinophilic myopericarditis in hypereosinophilic syndrome is eosinophilic myopericarditis, inflammation of the myocardium and pericardium due to eosinophilic infiltration. If you recollect, I had showed you the biopsy, which with a huge number of eosinophils that were infiltrating into the myocardium. Oftentimes, this occurs as a manifestation of hypereosinophilic syndrome. How do you define hypereosinophilic syndrome? It is persistent eosinophilia more than 1,500 cells per microliter, and evidence of end organ damage, commonly cardiac, skin, lungs, GI tract, nervous system, and so on. And the cardiac involvement in such cases is approximately 40 to 60% of patients with hypereosinophilic syndrome, and it can range from mild myocarditis to fulminant necrotizing eosinophilic myocarditis. If you recall my second patient, he came in cardiogenic shock with biventricular severe dysfunction. He was progressing rapidly, so this could possibly be a near fulminant variety of presentation of eosinophilic myocarditis. The clinical features and diagnosis, the patient oftentimes presents with chest pain, dyspnea, palpitations, and signs of heart failure, may mimic an acute coronary syndrome or viral myocarditis. That's why we completed angiogram in both the cases. Diagnostic evaluation, I've run through all of this. ECG shows STT changes with arrhythmias. Echo can show wall motion abnormality with pericardial effusion. Cardiac MRI, the late gadolinium enhancement in myocardium is seen, which I showed you. Endomyocardial biopsy continues to be the gold standard and shows an eosinophilic infiltration in the myocardium, as I had showed you in the biopsy specimen. Labs will show marked eosinophilia, and as I showed you in the first case, NT-proBNP and troponin can be elevated. Management, first line is high-dose corticosteroids. Fortunately for us, both the patients could be salvaged by just intravenous corticosteroids followed by oral steroids alone. The second line includes immunosuppressants like azathioprine, hydroxyurea, if they are refractory. Targeted therapy, this is the more advanced interleukin-5 agents like the pembrolizumab in selected cases. And of course, you treat the underlying cause, which can be parasitic infection or malignancy. If you recall, I had tested for the BRCA1 gene in both the patients, and fortunately for us, in both of them, it turned out to be negative. Thank you, everybody.
Thank you, Bhagirath, for the two wonderful cases. So any comments or points from Sandeep?
I think this emphasizes that if you have unusual and unexplained heart failure, you should actually do all the investigations. So sometimes we also do the same thing. You have to do an MRI, get a suspicion. You have to end up doing a FTG PET. We sometimes do a Dotanog because it's easier to arrange and you don't have to prepare for 3 days for that. So Dotanog we also found useful. Ultimately, you do have to do a biopsy. Sometimes you don't pick it up, but sometimes you do pick up surprises like this, and then it varies whether they'll respond to therapy or not respond to therapy. But yes, you have to go the full thing, because often you find treatable causes in an area where actually many causes are actually not treatable. So you do find things to treat if you go and do everything, especially with the recent way the MRI can be interpreted, the way Dotanog has come in now. So those things really help.
Question in the chat box: myocardial ischemia and edema can't go hand in hand, as in stroke cases where cerebral edema is often a sequelae of ischemia. Do we need to look at chronic inflammatory diseases when we see edema always? Bhagirath, any comments?
Myocardial ischemia and edema can't go hand in hand, as in stroke cases, where cerebral edema is often a sequelae. Do we need to look for chronic inflammatory disease when we see edema always? I think to a large extent, yes, because I need to find a reason why there is myocardial edema. Now, supposing, as I showed you in the first case, it was a case of ischemic heart disease as well, but and also the troponins were elevated. So the initial impression for us is whether it's an acute coronary syndrome. But these were stable coronary arteries lesions which were stented as a matter of fact. The reason why this lady came to our hospital is because she had evidence of pleural effusion, pericardial effusion, and the explanation for the raised troponin and NT-proBNP was actually the hypereosinophilic syndrome, and that was picked up by the MRI. So that way, we need to titrate and see which of the two etiologies is actually contributory to the myocardial edema. So it's as Dr. Sandeep mentioned, it's fair to run through the entire gamut of tests to understand exactly which pathology is contributing in which way to the patient. And many times we have to treat both of them simultaneously to get the best result.
Okay, thank you. We'll move to the next talk by Dr. Sandeep Seth on heavy hearts. Over to Sandeep.
Thanks.
So also cases.
Yeah. Okay. So this is basically a presentation which we had done in the European Society of Cardiology heart failure quiz competition, in which India competed versus Belgium and Serbia. And the title of this presentation was A Young and Heavy Heart. So let's see how it goes. So if you get a patient who's young and whose heart shows a lot of hypertrophy, normally you would think of certain fixed diagnosis. You think of hypertrophic cardiomyopathy, you think of amyloid or uncontrolled hypertension. But sometimes you end up getting surprises. So let's just see how this patient went. So this is a patient who is a 15-year-old boy. He was asymptomatic till the age of 12 years, and he's studying in class 7. And he's come now with symptoms of shortness of breath for the past 3 years. So 15-year-old, class 7, symptomatic for 3 years with shortness of breath. Dyspnea has gradually worsened from class 2 to class 3, and he's now symptomatic with NYHA3 for the past 3 months. Nothing in the past medical history. He's a vegetarian, no addictions. The family history is somewhat significant. On the maternal side, a maternal uncle had died suddenly at the age of 18 years. The details are not available, but he had died. Paternal grandparents are no longer there. There's no other significant family history here. On examination, we found no pallor, cyanosis ictus, JVP was normal, liver was not enlarged, there was no right-sided congestion, no pedal edema. Vitals were fairly stable, a pulse of 90 per minute, blood pressure 104/70. Respiration was normal, saturation normal, BMS slightly reduced, but 19.3. On clinical examination, the significant things that we found was a LVS4. Apex was displaced laterally to the mid-clavicle line and 6th intercostal space. On the investigations, this is the ECG. And I would like you to really pay attention to this ECG. What is obvious is that there's left ventricular hypertrophy, but look at this carefully again, because there are some clues in this, which I'll come back to later without revealing the thing right now. The X-rays, we had seen cardiomegaly on the clinical examination, so it reflected the cardiomegaly, nothing much that we could add to the information. Blood investigations were again somewhat interesting. Hemogram was normal and kidney function was normal. Liver showed that the liver enzymes were elevated, so 108 and 397, and bilirubin was normal. BNP, as expected, was elevated. So just note this thing, that liver enzymes are elevated, bilirubin is normal, kidney function is normal. And further, most surprise is that the CPK is elevated, CKMB is elevated, myoglobin is elevated, and LDH is elevated. So again, some very unusual findings. And this is the echo. So you see a 4-chamber view. There is a lot of hypertrophy. It's a hypertrophied heart. And the left ventricular function is also not so great. So some LV dysfunction and a hypertrophied heart can actually go along with a lot of differential diagnosis. Again, showing the same thing, showing that there's LV dysfunction and a very, very thick heart, a hypertrophied heart. There is trivial to mild MR. The LVOT is fairly okay, no obstruction of any sorts. Again, short axis showing that there is a very significant hypertrophy and some LV dysfunction. Showing the same thing. This is the IVC, so you can see that the IVC is normal. So the patient is not in right-sided condition as of now. We did a GLS, we do it in most of the cardiomyopathies, and you find that overall the GLS is somewhat reduced, and it's further reduced at the apex. This is the MRI. So again, showing what we had already seen in the echo, that there is extreme hypertrophy and there is some dysfunction. Multiple views showing the same thing. This is the LG, so it shows that there is a LG deposition in many parts of the ventricle. We did a T1 relaxation time. A normal T1 relaxation time is about 900 or so, so this was elevated. So T1 relaxation time was increased. Since we were not sure of what we were dealing with, and we had some things which were unusual, not fitting in with the usual diagnosis that we make between hypertrophic cardiomyopathy and amyloid. So things were not fitting in either way. We did a biopsy. So biopsy does not show features of disarray, does not show features of HCM, but is showing these cavitatory areas. We did a pass stain, which is not so very contributory. We did a electron microscopy of the same, and we found that there were some depositions in the myocardium. So since this was a quiz that we had presented, I've changed the options slightly to make it simple. The questions we had asked other teams, are we dealing with the standard hypertrophic cardiomyopathy, or is it one of the unusual phenocopy, that means something which mimics the hypertrophic cardiomyopathy but is somewhat different? So the possibilities we had suggested was Danon's cardiomyopathy, Fabry's disease, or Pompe's disease. So this is the quiz question we had put. We were lucky that none of the opposing teams could actually guess it, because it actually was a difficult diagnosis when we had made it also. Now, ultimately, we had at that point in this, when we had seen this patient, we had come up with the possibility of a Danon's cardiomyopathy, which is basically because of a mutation in the LAMP2 gene. And let me just describe the features of the various hypertrophic cardiomyopathy phenocopies, basically diseases which are exactly like hypertrophic cardiomyopathy, but have certain differences. Because when you see a patient who looks in every way like a hypertrophic cardiomyopathy, sometimes there are clues which suggest that it could perhaps be something different, especially because then your treatment will be somewhat different. Your genetic pattern of inheritance will be somewhat different. So one of the common differentials, not very common as a disease, but common differentials of hypertrophic cardiomyopathy should always be Fabry's disease, where there are certain clues. So if you look at Fabry's disease, the kidney is involved. There can be proteinuria, kidney failure. Eyes are involved. There can be problem with the eye in the cornea, and there can be neuropathy, neuropathic pains. So if you have a patient of what looks like a hypertrophic cardiomyopathy, but there are changes in the kidney like proteinuria, there's something in the eyes and there's neuropathy, and X-linked inherit. X-linked basically would mean in simple terms, most males will manifest with the disease. Females are less likely to manifest, and if they manifest, it will be a slightly milder version, but females will transmit. This is important because for Fabry's disease, there is a treatment available. That's where the importance comes in, that if you see a patient of HCM, always see, is it actually HCM or something different? So there is enzyme replacement therapy available for Fabry's disease. The next differential we had suggested was Pompe's disease, again a storage disorder. Usually, most of these patients present in a classic infantile onset. So this patient would not fit into that. That would be very early. It's very severe, very fatal. Some patients can present in middle childhood or in early or late adulthood. So how does Pompe's disease differ? You have some respiratory involvement, there's respiratory failure, there's cardiac failure. You have some GI problems, difficulty in swallowing, difficulty in chewing. What is important is you have proximal muscle weakness. So whenever we have a patient with what looks like hypertrophic cardiomyopathy, we do some simple tests in the OPD itself to see, are we dealing with proximal muscle weakness? Just make the patient fold his hand and try and stand up. If you find patient can't stand up even, then you know that you're dealing with some proximal myopathy, some simple things that we do. Also, if you have neurological problems, don't ignore these patients. There are, of course, many other differentials of HCM and neurological, but in this particular case, this is what we thought of. So Pompe's disease, again, if picked up early, there is an enzyme replacement therapy available. So both Fabry and Pompe have a potential treatment available. Then, of course, your standard typical hypertrophic obstructive or non-obstructive cardiomyopathy has autosomal dominant inheritance. The symptoms are fatigue, shortness of breath, angina, fainting, arrhythmia, sudden cardiac death. Again, if you find nothing else and the echo shows hypertrophy and there's nothing else involved, this would possibly be a case of hypertrophic cardiomyopathy. But in this case, our biopsy did not show dysuria, which is usually picked up. It can sometimes not be picked up on a biopsy. Finally, we come to the diagnosis that we had made, Danon's cardiomyopathy. How is this different? Now, when we saw this patient, he's a 15-year-old boy. He's studying in class 7. So obviously he's not in the correct class for this. So slightly perhaps mentally retarded. We did find that his IQ was somewhat less than what we thought. What is interesting is if you see the ECG has shown certain findings, which when I show you the ECG again, I'll show it again, but basically it showed pre-excitation and a short PR, which is not in any way expected in a patient of typical hypertrophic cardiomyopathy. So the triad of cardiac involvement, a proximal muscle weakness, skeletal myopathy, in our patient, all the muscle enzymes were elevated. So that suggested that the patient had a certain amount of muscle disease also and neurocognitive. These three things combine and make a possibility of Danon's disease somewhat more likely. And in case you have such a patient, it's very useful to go through the 2023 ESC guideline because they take each of the findings and give clues to what possible HCM phenocopy are we dealing with. For instance, if you start with the ECG, a short PR interval pre-excitant takes you towards one of the storage disorders like glycogenosis, Danon's disease, and Anderson-Fabry's disease. If you have extreme elevate, very, very large hearts, then again, Danon's disease and Pompe's disease become more prominent. As compared to that, if you have low voltage, then you think of things like amyloidosis or Friedreich's ataxia. Coming back to this ECG, if you see this ECG very carefully, there is, of course, hypertrophy. There's no doubt about that. But look at the pre-excitation and the short PR. So this straight away takes you to a possibility of certain different diagnosis also. So if you put all these things in a table, you have to look at the inheritance pattern. You look for any elevation of liver enzyme which are elevated in a patient who has no congestion. So it's not congestive liver enzyme rise. Pre-excitation, LVH on ECG, and myopathy. So the The one disease where all these things have happened to be there is Danon's disease. So if you look at the examination, the findings again, the liver enzymes are elevated, bilirubin is normal, the muscle enzymes are elevated. On ophthalmic examination, we found some changes. On neuropsychological examination, again, we found mild mental retardation. So everything was pointing towards Danon's disease. And then we did NGS for the LAMP2 variation, and we found that there was a mutation. So the diagnosis of Danon's disease was confirmed. So this was the mutation that we found. Now, what about treatment? Well, treatment, when it comes to treatment, these patients are in heart failure. So the standard management of heart failure has to take place. Many patients will respond, but you have to understand, if you're dealing with Pompe's or the Fabry's disease, you have an option of enzyme therapy. There are some initial case reports of gene therapy to correct the mutation in Danon's disease. So there is one case report which has come up that they have tried it in 1 or 2 patients, and they found that there is a drop in the BNP, the drop in the muscle enzymes. So very, very early results. Now, beyond drugs, many of these patients might not respond to drug therapy. You have to consider a heart transplant. In these 5 diagnoses, you have to understand, if you have to have a patient who's very sick, putting in an LVAD can be an issue, especially with a patient with hypertrophic cardiomyopathy, because all these hypertrophied hearts have very small cavities. And to run a LVAD, you need a reasonably large filled cavity. So there, putting in an LVAD can actually be a problem. So you have to straight away think of a heart transplant, not go via the LVAD route. Post-transplant also, you have to remember that many of these patients do have a proximal myopathy, which can be progressive, but fortunately, most of these conditions have a mild form of proximal myopathy. So if you manage these properly with good exercise and physiotherapy, you can manage these patients. So that was the case in brief. Of course, we'll tell you the result. We won the quiz against Serbia and Belgium. They were not able to guess this case, whereas we were able to guess their case. So thank you for listening to this wonderful presentation. I would like to thank all our colleagues in the All India Institute of Medical Sciences, because as you can see, lots of people are involved. Cardiology, cardiac radiology, cardiac pathology, neurology, to come up with this diagnosis, and the Heart Failure Association of India, who had given us an opportunity to compete as the Indian team against the European teams. Thank you very much.
Thank you, Sandeep, for that wonderful case. We know that you have won it for the second time this year. So it's all the more sweeter. So any comments from Bhagirath and Abraham?
Sandeep, I wanted to know, when you transplant such a patient, what always my patients ask me, what is the possibility of a recurrence in the transplanted heart? Is there a timeline? What to expect? How to approach this, and how would you answer this particular issue?
If we think in terms of the fact that the median survival of a heart transplant is 10 years, lucky patients will go to 20 years. So usually there are case reports only of Danon's disease. So the intermediate results are good. They have done quite well. So whether they will recur or not, we don't really have answers, because first of all, the disease is rare, but the enzyme will not be there in the transplanted heart.
Transplanted heart.
So we would hope that the disease would not come into the transplanted heart. What we have to focus more on, understand that the other components, the neurological components, the muscle components, those we have to take care of. So in the absence of definite large series, whatever case reports I've seen, the patients have done well, but then they've given follow-ups up till 5 years or so. That way, it seems to be a good last option.
Yeah. So how we approach is saying that for the transplanted heart to manifest this particular cardiomyopathy, Danon's cardiomyopathy, it's likely a timeline of 15 to 20 years. So if you get 15 to 20 years out of this heart, then we'll deal with it at that point in time.
Yeah, because the muscle mutation is not inside this heart. So that deposition of all the glycogen tissue will not happen in this heart, because this heart will have a normal muscle.
Normal one, but again through the circulation and so on.
Yeah, that can happen.
Okay, so nice cases and very good discussion. So I don't think there are any comments. Somebody has suspected storage disorder on seeing that slides. So thank you everyone for participating, and the next session will be the last in this physicians course. There will be a recap of the whole thing, and there will be a a final test, and you can print out your certificate once you complete the test successfully. So hope you all enjoyed this session. So thanks to the faculty, thanks to Sandeep and Bhagirath and Dr. Frederick and Sundar for that wonderful session, and Amit for summarizing the last session also. So see you all next Wednesday, 7 p.m. and good night.
Thank you and good night.